infertility, and in today's presentation, I will explain to you the links of endometriosis with ovarian cancer. William Osler stated, "He who knows endometriosis knows gynecology." The malignant transformation of endometriosis was first suggested by Sampson in 1925. He reported there was frequent co-occurrence in surgical specimens of invasive epithelial cancer and endometriosis, and chiefly the subtypes of ovarian cancer that was associated with endometriosis was endometrioid and clear cell cancer of the ovary. Endometriosis-associated ovarian cancer was seen in 0.14% of presumed ovarian endometrial mass. In my presentation today, I will cover 5 areas. I will talk about prevalence, histological types and prognosis, natural history, ultrasound and MRI diagnosis, theories of pathogenesis, and I will end with the impact of surgery and hormonal treatment. If you look at epithelial ovarian cancers, there are 5 subtypes. The most common subtype is high-grade serous ovarian cancer that accounts for about 80% of ovarian cancer and has a generally poor prognosis. The types of epithelial ovarian cancer that are associated with endometriosis are endometrioid ovarian cancer, which accounts about 10% of all epithelial ovarian cancer, and there's a double risk when patients of endometriosis of getting endometrioid ovarian cancer. And clear cell ovarian cancer tends to be common in Asian countries. Incidence is 10 to 25%, and the risk of getting clear cell ovarian cancer is 3 times higher with endometriosis. This study, which was a review of 15 published reports, found that the prevalence of endometriosis in women with ovarian cancer was 39.2% in clear cell ovarian cancer and 21.2% in endometrioid ovarian cancer, and very low in serous and mucinous cancers, as I explained earlier. Atypical endometriosis is more common in women with endometriosis that have ovarian cancer. It is found in up to 50% of endometriosis-associated ovarian cancer versus 1.7% in women without cancer. The transition from endometriosis to atypical endometriosis and transition from atypical endometriosis to cancer has been reported. And in fact, in this slide, which shows histological features of tissue from a single patient, you can see as you move from left to right, endometriosis, signs of early inflammation, atypical endometriosis, then you get an endometrioid borderline tumor, and finally clear cell cancer of the ovary. Clear cell cancer of the ovary and endometrioid ovarian cancer tends to occur in women at younger ages. So the median age of diagnosis of endometrioid ovarian cancer is 47 years old, and clear cell ovarian cancer is 55 years old. In terms of endometriosis, it is usually found in early stage, in stage 1, and the overall 5-year survival rate is about 90% because of this diagnosis in early stage. It must be clear, however, that clear cell carcinoma of the ovary tends to have generally a poor prognosis. It is a type of cancer that does not respond well to chemotherapy, and surgical excision is very, very important in the treatment of clear cell cancer. And we get quite good survival rates in clear cell cancer of the ovary associated with endometriosis compared to de novo clear cell carcinoma of the ovary because of the early stage of diagnosis. The lifetime risk of developing a clear cell ovarian cancer and endometriosis with associated ovarian cancer is about 1 in 59, which is 1.79% in endometriosis, versus 1 in 75 or 1.33% in all epithelial ovarian cancer. However, the lifetime risk of dying from ovarian cancer is 1 in 77 or 1.31% in postmenopausal women with untreated ovarian endometriosis. So this underscores the importance of following up patients who have ovarian endometriosis even when they go into the postmenopausal stage. And this is versus about 1% in the general female population. So there's no difference in progression-free survival between endometriosis-associated ovarian cancer versus non-endometriosis ovarian cancer. However, there's a better overall survival in endometriosis-associated ovarian cancer, chiefly due to the early stage of diagnosis. Endometriosis may not affect disease progression after the onset of ovarian cancer. In a retrospective cohort study of about 20,000 women hospitalized for endometriosis, women with long-standing endometriosis had a higher relative risk of ovarian cancer, and a follow-up study of this population showed that the highest risk was attributed to patients with ovarian endometriosis, no elevated risk with adenomyosis. So the chief risk is on ovarian endometriosis. We find that women who have peritoneal endometriosis as well as rectovaginal endometriosis don't have a higher risk of getting ovarian cancer. And this is attributed to the hormonal milieu in which ovarian cancer, ovarian endometriosis is subjected to, which I'll discuss later. Other factors associated with higher risk of ovarian cancer is endometriosis diagnosed at younger ages. So if we summarize the risk factors of endometriosis associated ovarian cancer, they are long-standing endometriosis, endometriosis diagnosed at an early age, endometriosis associated with infertility or a history of infertility treatment, ovarian endometriomas, de novo detection of an endometrioma during medical treatment, recurrent endometriomas, and patients with endometriosis who are not treated with hormones. While there's an increased risk of ovarian cancer in patients with endometriosis, it is important to put cancer risk in perspective. General risk of ovarian cancer in the general population is 1.3%. Ovarian cancer in patients with endometriosis increases to about 2%. However, patients who have got BRCA1 and BRCA mutations have much higher risk of getting ovarian cancer, as you can see in this slide. And even patients with Lynch syndrome also have a risk of ovarian cancer of up to 10%. And comparing with other cancers like breast cancer, lung cancer, and bowel cancer, you can see the risk of ovarian cancer is generally low. Moving on to natural history of ovarian cancer, I'd like to present to you findings from this very interesting paper that comes from Japan. This was a paper that comes from an area in Japan called Nagono, in which the primary teaching hospital used to get referrals from a number of smaller hospitals. And in the time of this study, they had a total of 543 cases of ovarian cancer. And the authors of this study were able to get the clinical and detailed ultrasound findings taken within the previous 12 months in 35 cases of these 543 cases. So of the patients who ended up having a diagnosis of serous ovarian cancer, you can see within the previous 12 months, there were either 2 patients with benign ovarian cysts and the other 9 patients with normal appearing ovary. And within a period of between 2 months and 12 months, a significant proportion of them ended up having stage 3 ovarian cancer. So you can see serous cancer developing to advanced cancer seems to occur very, very rapidly. In patients with endometrioid ovarian cancer, there was, however, a different picture. You can see here, most of the patients had a benign appearing cyst, 2 patients had endometriotic cysts, and 3 patients had a normal appearing ovary. And all the cancers that were developed, in all 10 cases, the cancers were in stage 1, with 9 of the 10 in stage 1A. In terms of clear cell cancer, there was slightly a mixed picture. 1 patient had a benign appearing cyst, and the other 7 patients had an endometriotic cyst. And you can see the majority of the patients here again were diagnosed with early ovarian cancer. However, 2 patients were diagnosed with stage 2 and stage 3 cancer. So you can see the duration of progression from normal ovary to benign cyst to cancer is relatively short. All the studies which have looked at ovarian cancer screening in the hope of diagnosing the cancer at an early stage. All the endometrioid cancers were diagnosed at an early stage. In serous cancer, progression from a normal ovary to stage 3 cancer occurred in 8 of 9 in a duration of between 2 months to 12 months. And in clear cell cancer, progression from endometriosis to cancer occurred between 4 to 10 months, with 5 of the 7 diagnosed in early stage, and 1 patient in stage 3 disease. Going on to the ultrasound and MRI aspects of endometriosis and ovarian cancer. Ultrasound is a very common tool used in the diagnosis of endometriosis and in and the assessment of patients with endometriosis. These pictures come from the previous Japanese study that I described to you, and it's a single patient's ultrasound pictures followed up over a period of time. So this lady in February 2000, when she was 39 years, had a typical appearance of endometriosis with a typical ground glass appearance. However, by July 2002, there was lucency in the cyst appearance, and it looked echolucent. Then by February 2003, there was a mural solid nodule seen, which showed increased flow on Doppler, and this lady was diagnosed with an endometrioid adenocarcinoma of the ovary. Other authors have described different appearances. This is a picture from an article by Nezat. Here again on the left, typical endometrioma with diffuse homogeneous hypoorganic features, the typical ground glass appearance. And then there is endometrioma with some mural malignant features in the same patient seen. In another patient, you can see again typical endometriotic picture on the left. And over time, when this patient was followed up, there was development of a mural nodule, and this patient also had a diagnosis of ovarian cancer. The best tool for making a diagnosis of a mural nodule and looking for features suspicious of ovarian cancer is to use MRI. And you can see the picture on the left is a mural nodule seen in a cyst of a patient who had an ovarian cancer. And these were the specimens on the right that you can see when the ovarian mass was removed at surgery. So MRI picks up hyperdense mural nodules. Clinical features are also important, and rapid growth of endometrioma is associated with malignant transformation. In a cohort study carried out by Japanese researchers comparing 10 patients with ovarian adenocarcinoma with 10 patients with trauma, mural nodules were seen in all 10 patients who had malignancies versus 3 of 10 patients of benign causes. So clearly MRI can help in the diagnosis, and it's usually also good to look at the clinical progression of the patient. Moving now to theories of pathogenesis. There are a number of theories of pathogenesis. There are some association with genetic factors. There is a hormonal factors being implicated, as well as pro-oxidant factors related to hemorrhage. So the first theory, genetic factors, endometriosis that looks benign already has genetic defects, and ovarian cancer may arise within this lesion. Allotyping of endometriosis and along with adjacent ovarian carcinoma has found common genetic alterations. Example, the P10 gene mutation, genetic mutation in HNF1B and ARIDA also are related to the onset of clear cell and endometrioid cancer from endometriosis, and alterations in BEL2 and P53 may be involved in the genetic alterations of endometriosis. The second theory is regarding ovarian factors, and this theory states that as increased estrogen persists in the microenvironment of endometriosis implant in the ovary, this alters the physiologic milieu around ovarian surface and proliferation with increased chance of DNA damage and mutation. And this theory attempts to explain the observation that only ovarian endometriosis is associated with increased risk of ovarian cancer. When you have peritoneal deposits, adenomyosis, rectovaginal endometriosis, there's no increased risk in ovarian cancer. The last theory is regarding the theory of retrograde menstruation, which was advocated by Sampson way back in 1925. We know that retrograde menstruation or ovarian hemorrhage carries highly poor oxidant factors such as iron into the peritoneal cavity or ovarian endometrioma. Repeat events of hemorrhage in endometriosis can contribute to carcinogenesis and progression via three major processes, that is, increasing oxidative stress promotes DNA methylation, activating anti-apoptotic pathways supports tumor promotion, and aberrant expression of stress signaling pathways contributes to tumor progression. So these are all theories and various explanations that have been put forward to explain why patients with endometriosis get ovarian cancer. Now, this is an interesting study that looked at 76 consecutive patients with stage 1 ovarian cancer. And this study showed that there was an increased risk of endometrial carcinoma as well as endometrial hyperplasia in endometrioid cancer of the ovary, as well as mixed endometrioid and clear cell cancer of the ovary. In fact, endometrial abnormalities occurred in 36% of patients. So therefore, it is also important to assess the endometrium when you have a patient with early ovarian cancer associated with endometriosis. There are some predictive factors for the presence of malignant transformation of ovarian endometriotic cysts, and these are elucidated in this paper. Malignant tumors were found to have significantly higher risk in cysts that were larger cysts. A cyst of 14 centimeter versus 7.5 centimeter was significant. Cysts that were multilocular also had a higher risk of malignancy. And the most important factor was solid components within the cyst. Solid components on imaging had an adjusted odds ratio of 23.7. There was also an association with increased age. For every 5 years increase in age, there was an adjusted odds ratio of 2.17. CA125 levels were found higher in malignant tumors, but did not reach statistical significance with a mean of 204.9 versus 66.9. As far as CA125 is concerned, we know that in general, it has been found to be a poor screening modality for ovarian cancer, generally because in early ovarian cancer, stage 1, only about 50% of patients have elevated CA125. We know that CA125 is lower in endometriosis-associated ovarian cancer compared to patients with non-endometriosis-associated ovarian cancer, with a mean of 122.9 versus 1,377.5. 32.6% of patients with early-stage endometriosis-associated ovarian cancer had normal CA125, chiefly related to the early stage of diagnosis. Lastly, I'd like to end with discussing the impact of surgery and hormonal treatment. Information regarding this comes from two registries in Sweden. There's a national Swedish patient register that looked at all women with first-time discharge diagnosis of endometriosis between 1969 and 2007. And the authors link this registry with the National Swedish Cancer Registry, where all patients diagnosed with epithelial ovarian cancer at least 1 year after the endometriosis diagnosis was studied. This study showed that if you performed a unilateral oophorectomy in the ovary involved with endometriosis, there was a risk reduction in risk of epithelial ovarian cancer. And the odds ratio of this was 0.19, which is an 81% reduction. If the surgeon had complete extirpation of endometriotic tissue within the pelvis, then there was a reduction in ovarian cancer risk of 0.30, which is a 70% reduction. So the type of surgery that you do has an impact on the risk of the patient developing endometrial ovarian cancer subsequently. So based on this study, the authors calculated that the lifetime risk of ovarian cancer for women in Sweden with endometriosis was 1.5%. Risk reduction of 30% for ovarian cancer if all endometriosis is surgically removed, and you need to operate on 95 patients to prevent one case of ovarian cancer. Lifetime risk of ovarian cancer for a woman in Sweden with ovarian endometriosis is 2%. There's a risk reduction of 81% if the affected ovary is completely removed, that is a unilateral oophorectomy, and 65 patients are needed to have a unilateral oophorectomy to prevent one case of ovarian cancer. Hormonal treatment also has been studied by some authors in endometriosis, though there's not a lot of data looking at this. We know if you look at endometriosis, hormonal treatment is more effective following surgical excision of endometriomas and endometriosis compared to just operating patients and then following up. We also know that in endometriosis, oral contraceptive use for more than 10 years is associated with 80% reduction in ovarian cancer risk among women with endometriosis. There's also studies to show that diligent post-operative oral contraceptive use versus sporadic use is inferior with an odds ratio of 0.21 when you look at ovarian endometrioma recurrence. Progesterones also have been studied as adjuvant treatment after endometriosis. And there's again not a lot of clinical data, but there are some lab studies. For example, this study showed that Dynogest suppressed the in vitro proliferation of endometrial cancer-derived cell lines, which failed to respond to other progesterones. So it's thought that this could be a superior progesterone as far as cancer risk is concerned, and a number of mechanisms have been proposed. This is all theoretical, but they think it can act by ovarian inhibition, acts by direct progesteronic effects. There's reduction of inflammation with this progesterone, increased apoptosis, and also reduction of angiogenesis. So in summary, 1.3% of women will develop ovarian cancer in their lifetime. There is an association between endometriosis and clear cell, low-grade serous and endometrioid ovarian cancer. Overall risk is low with a risk ratio ranging from 1.3 to 1.9. Lifetime risk is increased from 1 in 100 to 2 in 100 in patients with endometriosis. Endometriosis is associated with an increased risk of ovarian cancer. However, the cancers tend to be early stage. They are also low grade, and the histology is endometrioid as well as clear cell. Endometriosis associated ovarian cancer, when detected at an early stage, has a better prognosis. The natural history has been described in the Japanese study, and we know that endometriosis may not affect progression after the onset of ovarian cancer. Lastly, endometriosis associated ovarian cancer has got certain risk factors, and these patients should be followed up more diligently. That includes long-standing endometriosis, endometriosis diagnosed at an early stage, endometriosis associated with infertility and a history of infertility treatment, as well as de novo endometriotic cysts, which develop while a patient is on treatment. Reduction in risk of epithelial ovarian cancer can occur with surgical resection. Risk reduction is 30% if all endometriosis is surgically removed, and the risk reduction is 81% if the affected ovary is removed. Thank you very much for your attention.
Thank you very much, Dr. Suresh, for delivering that lecture. Since this is a memorial lecture, there is no Q&A after this. Please stay tuned for the upcoming, our first plenary lecture coming on in a few minutes. Welcome back. We are very, very, very privileged to have with us today Dr. Vijay Roach, the current president of the Royal Australian and New Zealand College of Obstetricians and Gynecologists, FRANZCOG. He has been the chair of Continuing Professional Development Committees, the Engagement Committee, and the Training and Accreditation Committee in Australia. Dr. Roach is passionate about teaching and places great emphasis on the value of compassion and kindness in medicine. We cannot think of a more apt speaker for the next topic, medical leadership. Dr. Roach?
Thank you very much, Dr. Hu, and thank you for the kind invitation. And I'd like to acknowledge Dr. Muralitharan Gunasalingam, and also in particular my friend Dr. Harris, and the kind invitation from the organising committee to join you for your 28th OGSM conference. Not one that we ever anticipated will be held in this way, but it is what it is. And as we were talking about just before we joined the online forum, was, yes, we're fed up. We're sick of being locked down. We miss our friends and our family. And in particular, I would like to be with you. Thank you to OGSM for signing a memorandum of understanding with FRANZCOG, and greetings to all of you from your friends and colleagues in Australia and New Zealand. So I thought I'd start by telling you that whenever I have the opportunity, I tell people that